All right. Good morning, good afternoon, good evening to everybody. Welcome to the first CMR Journal Club of 2025. We are really excited to have you all with us today. So I'm Nicole Cyberlick from the University of Michigan, and I will be moderating today. And the topic for our journal club this week is how we can look at the effects of COVID-19 and vaccinations using CMR. So we have two papers which discuss how we can use MR to study the effects of COVID. The first will be presented by Dr. Supriya Jain along with Dr. Lars Grosse-Wortmann, and our second paper will be presented by Dr. Rafiee. So at this point, I'm going to ask Dr. Jain to share her screen, and we can take a look at the paper. She can go ahead and take it away at this point.
Thank you, Nicole. Do you think I can share my screen?
Are you able to share?
It said I had to send you a request. So, oh yeah, I think I can.
Okay, perfect.
Can you see my screen?
Yes, we can see your screen now.
Let me just make that bigger. Okay. All right. So thank you for giving us this opportunity to present our study findings of MACiV. This is myocarditis after COVID vaccination. It's a multi-center study, and I just want to highlight this was a big collaborative effort, mainly by the CMR members, and so it really speaks to the true spirit of collaborative research. And you can see all these centers. The investigators across 38 US sites, and the title is Cardiac Manifestations and Outcomes in COVID Vaccine-Associated Myocarditis in the Young in the US. The study was funded by the FDA. So just briefly, in terms of the background, what led us to initiate the study, this was back in April 2021, when the first few cases of COVID vaccine-associated myocarditis, which I'm going to refer to CVAM, it came to light, and a few of us, as we all know from the SCMR, we have a robust WhatsApp group. We shared cases. It was concerning to many of us with the findings which we found on the CMR. A few of us had experiences with the management of MISC patients. These were pediatric patients who were affected with COVID. And although they didn't have direct COVID infection, it was a delayed hyperimmune response. And we had some perspective of the CMR findings. And this led to an initial pilot series across at least 18 sites across the US. And we published in August 2021 the first report of patients with CVAM in the pediatric age group studied with cardiac MRI. Where we found a pretty impressive prevalence of LGE on CMR. Since there was very little information at that time in terms of the prognostic implications of myocardial injury in these young patients is what led us to expand the efforts, recruit more sites. And we were fortunate to have 38 sites in total come together, and we had around 333 patients of CVAM and 100 MISC patients which were enrolled in this study. So this was a longitudinal multi-center retrospective observational study, and we included patients who were 30 years of age and less with the clinical diagnosis of CVAM. Based on the CDC criteria. We looked into their demographics. We collected their medical history, hospital course, lab results, all their cardiovascular imaging, and follow-up information from April 2021 to November 2022. We stratified them into a younger age group, 5 to 15 years of age, and older, 16 to 30 years of age, mainly reflecting the way how the vaccine was rolled out by the FDA. We included as a comparison cohort the MISC patients, since that was one of an important complication of COVID-19 in the pediatric age group with frequent cardiac manifestations, which the vaccine sought to prevent. And so we included those MISC patients who had CMR during the acute and subacute phase of illness. So the things which we looked at. And just to highlight the few things, the strength of this paper was that, which eventually we looked not only at the detailed phenotypic outcomes. One of our other aims was looking and exploring into possible risk factors for myocardial injury. And so we wanted to compare the outcomes and follow them longitudinally. So in terms of the methods, what we try to do is to compare clinical courses between CVAM and MISC. We defined greater than mild clinical severity if any of them had presence of either ventricular arrhythmias, significant pathological ventricular arrhythmias, LV systolic dysfunction, need for any inotropic medication, mechanical ventilation, heart transplantation, or death. And in terms of the CMR, while we looked into right from ventricular volumes to edema, myocardial injury, LGE, parametric mapping, to assess the severity of myocardial injury, we stratified the patients based on LGE severity. Greater than mild LGE severity was defined as anyone who had multifocal or transmural LGE, or 4 or more than 4 American Heart Association segments which were involved with the LGE. Our primary outcome was LGE at initial presentation, and our secondary outcomes, we looked at presence of any LGE at follow-up, presence of any cardiovascular symptoms, mainly chest pain, palpitations, shortness of breath, syncope, any significant ventricular arrhythmias, AV blocks, LV, EF less than 55% on echo, listing for heart transplantation, rehospitalization, or death related to a cardiac cause. So just briefly going over this table, I know it looks very busy, but I'm just going to highlight a couple of things here. So we looked at the CVAM group and the MISC group, and we even looked at the different age groups, so less than 15 years of age and greater than 15 years of age. And so few things which I want to highlight, and then I'm going to highlight it on the figures which we have in the subsequent pages, is the CVAM patients were older compared to the MISC patients. They were predominantly males and white compared to Black patients in the MISC cohort. The presenting symptoms, 96% presented with chest pain, and 96% of them had elevated troponin, compared to the MISC group, which presented more with fever, GI symptoms, and they had an elevation in CRP and ESR. The hospital course, if you see here, it was way milder in the CVAM group. They had a shorter hospital stay. They had less ICU admissions compared to the MISC group. And also the need for mechanical ventilation, ECMO, was lower in the CVAM group compared to the MISC cohort. Moving on into the cardiac imaging, here you can see that interestingly, while LV dysfunction was much more prevalent in the MISC group, the CVAM patients, only 17% of them had LV dysfunction, and majority of them were all in the mild range. They only had mild LV dysfunction. But in the MRI findings, the prevalence of LGE was way higher. It was 82% in the CVAM group compared to the MISC group, which was 16%. And also in terms of the LGE severity and the involvement, the number of LGE segment involvement, it was higher in the CVAM group compared to the MISC group. So here's a diagram. This just gives the age distribution of the CVAM patients. And what I want to highlight is these were the adolescent group. So the higher the patients which were more in the age group of 14 to 18, with the highest in the 15 to 16. So the mean age was, and CVAM patients were, they were 15-year-olds. And what this diagram here, this is the AHA segments where it explains the or demonstrates the frequency of LGE involvement. So this is the initial CMR, and mainly it was in the mid and the basal inferolateral segments of the LV where there was a higher prevalence of LGE. And we'll talk about the follow-up, but you can see that there was definite improvement on the follow-up CMR. So I'm going to talk about the follow-up and the outcome, and I'll come back to this diagram once again. But just going onto this paper, just want to talk about the risk factors of LGE and CVAM.
Dr. Jain, I'm sorry to interrupt. We have about 2 more minutes for,
okay.
I know, it goes fast.
I will be really quick. Oh, sorry, I didn't realize that. Okay, so let me quickly go on the risk factors. As you can see in this diagram, the odds of having LGE was higher if you were a male compared to female, if you an older age group, greater than 15 years of age, and also if it was higher in the first and second dose compared to the third dose. Going on to the outcomes, we had follow-up information in 92% of our patients, and a median follow-up duration of 178 days. There were no deaths or need for heart transplantation. Arrhythmias were very low at 4%. LV dysfunction, which was seen earlier, had resolved. The CMR findings of LGE, myocardial edema had all decreased. The only concerning part was at least 60% of them still had persistence at their follow-up exam. And so the main findings of the study is that, although there's a mild initial clinical course and low prevalence of cardiac dysfunction, the myocardial injury is very much common in the CVAM patients. And although the midterm clinical outcomes are very reassuring, I think we still need to follow these patients longitudinally to understand what happens to myocardial scars long-term, especially with what we know from the adult myocarditis literature, that this could be risk factors for cardiomyopathy, heart failure, arrhythmia, or sudden cardiac death. So this is, again, just a diagram which explains we do not know the prognostic implications, and we do need long-term studies. The figure 6 here is just showing in terms of speculated pathophysiology between MISC and CVAM, where we think with the CVAM, there is probably a directed cardiomyocyte injury, as evidenced by elevated troponins and the biomarkers and the CMR markers being abnormal, versus in MISC, it's more of a systemic inflammation where the systemic inflammatory markers are elevated, but there's not so much of a directed injury into MISC. And so to conclude, CVAM patients need to have a long-term follow-up and monitoring with clinical visits, echocardiograms, heart rate monitoring, and at least in the patients which are LG positive, they need to be followed up, which is what we are planning to do in our long-term study, which is ongoing currently.
Awesome. Thank you so much. So we're going to open the paper for questions, and it looks like Matthias already has his hand raised. So I'm going to hand off to Matthias.
Yeah, no, I just wanted to, in the interest of time, I just want to congratulate you for this fantastic initiative. The history alone of this initiative is a role model of how research should be initiated. A wonderful study, and so clinically so relevant, and it points to the importance of tissue characterization. No other imaging modality can provide that, and in this case make really game-changing or provide game-changing information, which has a lot of significant impact on the population, especially the younger ones. So I'm so happy that you did that, Supriya and Lars and all the others that participated. Just one quick question regarding the role of edema. Have you thought about that? I know LGE is important because it has a prognostic significance, but sometimes it was interesting to see in early stages, does edema have a more positive aspect, being reversible, and then having, but other papers said edema has a more negative. So in this case, where you differentiate between a primary injury in the vaccinated versus a consequence of a severe systemic inflammation, is in MACiV, I would be interested in the role of edema. Just was wondering whether you by any chance looked at that as well.
I'm happy to answer, but I think I'm going to give Lars a chance to speak, and then I'll chip in.
Sure, we can both speak to that briefly. Thanks, Matthias, for your encouragement too. One shortcoming of this study was that we did not do a core lab analysis for our pictures. You know, we wanted to get the results out relatively quickly, and we will do that in our follow-up study that Supriya mentioned. We did, however, collect data on edema, T2 mapping where it was available, and T2 weighted signaling increase as per the Lake Louise guidelines. One thing, we didn't find any prognostic information in there for outcomes, but one thing that puzzled us was that edema seemed to be less prevalent in these MRIs than the LGE. So much so that some of them actually did not fulfill the Lake Louise criteria. And, you know, I know there's a lot of research that you, Matthias, and others have done on the significance of edema. So we found that intriguing. We also went down a rabbit hole a little bit to ask the question whether the Lake Louise criteria, which were really originally, at least in 2009, you know that better than anybody, developed to differentiate myocarditis from ischemic heart disease and MI, whether they apply in the same way to the pediatric population, in which the question for MRI is often much different. It's not to differentiate a coronary problem, but a dilated cardiomyopathy. Anyway, we'll hope to look at that in more detail when we get the actual core lab analysis on some of these.
We have to wrap up, but this is so important, and it may indicate to me that the inflammatory response is not good enough to control the aggressor, and that may be an interesting aspect to follow. So, but back to Nicole, I think you have to.
Yes, Matthias, there's a lot to discuss. So yes, Lars pointed out, this is one of the things about the LLC, which we need to figure out in our pediatric population.
Yeah.
Thank you.
Awesome. Yep, thank you all for this great discussion. And at this point, we have to move to our next paper. So thank you again, Drs. Jain and Grosse-Wortmann. So if Dr. Rafiee could share his screen, we can move on to our second paper. Perfect. Okay.
Yeah. Okay.
Yeah, we can see it.
Yeah. Thank you so much for inviting me. This is the review article about the cardiac involvement in COVID-19 with the cooperation with Dr. Friedrich. It gives me a sense of nostalgia when I discuss about the this article. So briefly, from beginning of this pandemic to October 2023, it causes about the 7 million deaths, and you can imagine the Austrian population is about the 9 million, and the Switzerland is 8 million. It's not just the numbers, and how bad was that? And this virus, it's belonging to the coronavirus. Virus, it's a zoonotic virus, and mainly affects respiratory and cardiovascular system because there's abundant of SARS ACE2 receptors in these organs. But it's the systemic disease, of course. The risk factor for mortality in COVID-19, it's age, sex, and the comorbidity. And we found during the review of articles that the patient who died during hospitalization, majority had the cardiac involvement. So the American College of Cardiology and European Society recommended using of cardiac MR to evaluate of cardiac injury in patient with the COVID-19. So the next part is about the myocardial injury in COVID-19. We can categorize broadly in two types of injury, ischemic and non-ischemic. The majority cause of the ischemic myocardial injury is related to plaque rupture and erosion as a classic pathway for myocardial injury, but we found that the a significant number of patients with ischemic injury during COVID-19 at the MINOCA might be due to direct endothelial infection by virus or thrombosis, micro or macrovascular thrombosis due to massive cytokine release. And the second type of myocardial injury is non-ischemic injury. And the interesting, occasionally it's from direct viral infection of cardiomyocyte. A majority of a non-ischemic myocardial injury, it's related to immune response and the hyperinflammatory during the disease. About the histopathologic finding of COVID-19, unfortunately, our knowledge about the exact histopathologic findings very sparse, and it's just related to some post-mortem examination of the patient who were dying during the acute COVID. But this evidence suggests the vascular leakage and the myocardial edema were the principal contributor to myocardial injury. There are several mechanisms for myocardial edema during the COVID infection. We think that the most important part is down regulation of ACE2 receptors as a major way to entry the virus to the cells, and it's led to increase angiotensin 2 and the activation of kallikrein bradykinin pathways. The other mechanism for myocardial edema could be due to endothelial infection and the capillary dysfunction and the surge of inflammatory cytokine and vasoactive molecules. In the post-mortem examination, about the 300 patients who died from severe COVID-19, and they found that the myocardial injury based on the Dallas criteria was only about the 2% of cases. So you see there is not the classic pathway to myocardial injury as the other viral infection. The next step that we discussed about the imaging assessment of COVID-19. The endomyocardial biopsy, of course, the gold standard, but it's very invasive, and during the acute infection, it's very dangerous. Just they recommended only in patients with the very severe and complicated cases or patient who didn't respond to standard treatment like the high-grade heart block and ventricular arrhythmia. So the consensus decision suggested that the transthoracic echography is the first modality to evaluate the patient who had the evidence for cardiac involvement based on the clinical symptoms or paraclinical findings. Despite the limitation of the echocardiography, this modality showed that the half of patients had some evidence of LV dysfunction and the change in management in about the 1/3 of patients. The main disadvantage of echocardiography was that limitation to show the tissue characteristic. As we discussed before, the main mechanism to myocardial injury in this group of patients was the myocardial edema. So based on this finding, cardiac MR is the best method to show the cardiac injury during the COVID-19, not only show the global and regional RV and LV dysfunction, it can show the T1 and T2 changes based on the myocardial edema and fibrosis, and also can show the myocardial replacement fibrosis by LG, and can differentiate between the ischemic and non-ischemic cause of myocardial damage. As the standard criteria for cardiac MRI to show the myocardial damage, it's Lake Lewis criteria, and I want to show the diagram of Lake Lewis criteria based on the 1 T2 abnormality based on the T2 map or T2 to show the myocardial edema, or T1 based imaging modality to detection the myocardial injury and fibrosis as a regional increase T1 relaxation time, LGE, or increase extracellular volume, and the supportive criteria like the pericardial effusion, pericardial enhancement, or abnormal LV function. We found that although the cardiac MR is very useful to detect the myocarditis, but in the patient with acute COVID-19, it's underutilized because there's limited accessibility in the most of the countries. And the patient with the difficult breathing and dependent to accessory machine and the hemodynamic stability, there is the very underutilized. So pattern of myocardial injury during the cardiac MR is very different. It could be myocarditis, pericarditis, myopericarditis, ischemic injury, and the stress-induced cardiomyopathy. The majority of the studies have shown that the myocardial injury in this group of patients, it could be global myocardial abnormality as increased T2 value that shows the myocardial edema, and or increased myocardial T1 that indicated the myocardial fibrosis. A large international study has shown that the standard and standard evidence for myocarditis during the COVID-19 was only in 4 patients per 1,000 patients. As you see, there is the moderate sensitivity of the cardiac MRI to diagnosis of myocarditis based on the Lake Lewis criteria. But we found that in patients with a very suggestive clinical scenario, one abnormality on T1, or especially on T2, that shows the edema associated with one suppurative criteria like the pericarditis or pericardial effusion, can suggest the cardiac involvement in the patient with myocarditis. So I want to show you the one of the patients. Here we were lucky to the patient had the just full criteria of Lake Lewis criteria for myocarditis, is increased T2 maps and the edema in the infraseptal part and the subepicardial enhancement. And The other advantage of the cardiac MR in patient with COVID-19, demonstration of right ventricular dysfunction, and it's associated with the poor prognosis. And here is another patient that you see the dilated right ventricle associated with the subepicardial enhancement. So, yeah, there is another important part of COVID-19 in the athletes. Given the myocarditis accounts for about the 10% of sudden cardiac death in young and active adults, there was a very significant concern about the consequences of COVID-19 in young and very active adults. But fortunately, a very large multicentric study in 13 universities that showed that there is very low risk of myocarditis in this group of patients. And even cardiac MR show about the 0 to 7% of evidence of myocarditis in this group of people. Also, there is
Dr. Rafiee, I'm sorry to interrupt.
significant false positive of cardiac MR findings in the athletes. It could be due to fibrosis in the RV insertion point. So as you see, there is a very low risk of adverse cardiac events in the athletes group.
Dr.
And
Rafiee,
I'm
not sure if you can
testing
hear.
the cardiac MR in the children. And the last part is
may
the
not be able to hear you,
COVID-19
Jawad.
vaccine-related cardiac
Can you hear us?
injury. That's as the first speaker said, there is risk of myopericarditis in group of patients with mRNA-based COVID vaccination.
Yeah, so
Oh, Dr.
Jawad?
No, sorry.
Can you hear us now?
Let me see. Sorry.
Are you able to hear us?
Yes.
Perfect. I'm just going to ask you to wrap up in the next 2 minutes so that we can have a quick
This
question.
is the last part.
Perfect.
Yeah, this is the last part. Yeah.
Okay, thank you.
Yeah. During the review article, we found this about the 18 cases per million dose of mRNA COVID-19 vaccination, and it depends on the age, sex, and vaccine type and dose. The highest risk of cardiac injury in this group of patients, it's young adult male, specifically after the second COVID-19 and during the first weeks after the vaccination. The pathophysiology, it's unclear, but we think that the major cause of the vaccine-related myocarditis is hypersensitivity reaction. And the imaging finding in cardiac MR is quite resemble the other type of myocarditis. Here is the example of the patient after the after the second mRNA vaccine dose. As you see, there is the subepicardial enhancement in the basal to mid, inferior, and infralateral, and the some area of abnormal T1 and T2 mappings. So the final part of my talk, it's this diagram that shows the different pattern of myocardial injury during the COVID-19, during the acute and the post-COVID part. And the because the COVID-19 has different way to affect the heart, the imaging finding is quite different, and the symptoms and the pretest probability, it's quite helpful to diagnosis of myocardial injury during the COVID-19. So then, thank you so much for hearing my talk. And Dr. Friedrich, do you want to add some things?
No, thank you very much.
Perfect. Thank you, Dr. Rafiee. So I'm going to open this paper for questions as well. So if you have a question, feel free to write it in the chat or unmute yourself and you can go ahead and ask. Maybe while we're waiting, I'm going to ask maybe the more layperson question, which, we had some discussions about, myocardial injury due to vaccination and then due to COVID itself. And Dr. Rafiee, if I'm correct, you said that there was like a 2.5 to 4% myocardial involvement or damage due to infection with COVID itself. Is that correct?
It's based on the Lake Lewis criteria, yes, because we think that the myocardial injury, it's not only related to direct myocardial infection. The main reason for myocardial injury or damage or involvement, it's myocardial edema. So the Lake Lewis criteria itself cannot explain or diagnose the cardiac injury in this disease. So we have to use the other part, especially mapping.
So is that an underestimation? Is that what I'm understanding? That if you stick with the Lake Lewis criteria, you have
yes,
it looks like there's less involvement. Okay.
Yeah,
and
exactly.
So maybe I missed it. Do you have like an estimate of how many, COVID patients do end up having substantial myocardial involvement? Like what percentage?
There is no standard study because the timing is very important. We don't do the cardiac MRI during the acute phase because, as I explained, there is a lot of problems. Usually, near all of the patients that did the cardiac MR was in the recovery phase.
Got it.
So it could be the reason why we don't have the standard or usual pattern of myocardial injury, plus the mechanism of myocardial injury in the COVID-19 is very complex.
Right, so different, yeah. Yeah, go ahead, Matthias.
Just very briefly, I think it's an important question. What's the relevance of myocarditis and persisting injury in COVID-19? And we do not have good population-wide data. That's we have to. My wild guess would be it may be something between 2 and 5%, which doesn't sound like a lot, but given the high
huge numbers
of patients, I think it's a significant issue. There are old data on autopsies where up to 8% of people who died of any cause had myocardial scars indicating previous myocarditis with necrosis. So 8%. So if we now consider 2 to 5%, so we may be in the range around 5% of the population that may be affected by that. So just as a
that's huge.
ballpark. Yeah.
All right. I know
luckily in healthy people you have a lot of myocardium compensating for that, and so it is not necessarily as bad as having myocardial infarction. Just also to say that very clearly.
And I know we're running a little late, but I do want to just kind of bring this back to Dr. Jain's paper. So, in terms of the number of, again, this is a very layperson's perspective that, the question is like, is vaccination worse than the actual disease, right? But there's people who ask this question all the time, especially when it comes to myocardial involvement. So what is the, relative fraction, the percentage of people in the age group, that you studied that ended up with vaccine-induced myocarditis? Is that a large number, or how does that kind of relate to this number that we're talking about here?
So Nicole, that's a question which we ask ourselves and which, with our discussions with the FDA frequently. So one thing which to note is, definitely in our cohort was a selection bias, right? So these were presented with CMR. But saying that, even though there was a selection bias, 72% of our patients had CMR, but anybody who went into the scanner had LGE, like 82%. That was pretty
Hi,
impressive.
yeah.
Like we all scan patients with myocarditis, right? And so, yes, the numbers were very much similar to what the adult data for viral myocarditis is. But I think that is what the take-home message is. Like, we don't know if anybody walking around with CBAM, has it. But if somebody has chest pain, troponin, then maybe it may not be such a bad idea to, put them
Get a
into
CMR, yeah.
and see, what the patient has. And just the last note from the paper, which was just presented, between the acute COVID-19, the injury, and where you see so much of edema and where we did not see the edema. And again, knowing our limitations, that's a retrospective study. Definitely the mechanism seems to be very much different. Is, why didn't we see this here? Why did we see more of LGE
Right.
here? So that really points it to the fact that more studies are needed into understanding this particular pathophysiology, and then definitely the longitudinal outcomes in all these subset of patients is something which we all should be doing.
Awesome. This was a really great way to wrap this stuff up. I'm so sorry we went a little bit over, but I think it was worth it to kind of bring these two papers together. So I really, really appreciate everybody staying on. I just want to remind, well, first I want to say thank you to our presenters one more time, and remind everyone on this call that we're going to go back to our normal 11 a.m. time next month. We moved it a little bit due to a conflict that we had with the JCMR Journal Club, which is the second week of every month. We moved ours due to the 1st of January. So next month back at 11, and Matthias is going to at least I think give us the topic for next month.
Yeah, so no, it's unfortunately I cannot give yet the confirmed authors, and because I need both papers for that topic, I also cannot announce the topic, but I will
no
do so
problem.
as soon as I can.
All right. Well, then that's a little bit of a teaser.
Right
Something
after
interesting.
Eskimo.
All right, great. Then stay tuned for information about the February Journal Club. And thank you all again for joining us and accommodating the adjusted time this month. And we'll see you in February.
Thank you for having us.
Thanks.
Have a great day,
Supriya.
everybody.
Thank
Well,
you so
thanks
much.
a lot. Bye.